The spot film taken from IVU examination, in which you see that the right-sided pelvic ileal system looks normal, there is no hydronephrosis, etc. And then on the left side, when you see mild hydronephrosis of the left pelvic ileal system. The left ureter is outlined with contrast, and here at the level of distal ureter, you find some pooling of contrast, which is extending towards the left side. So this was a case of a ureteric injury due to surgery for endometriosis. It can happen, this ureter can be injured while gynecological surgeries, and in that case, this examination is often required. The other examination that can be done is CT-IVU, in which case a delayed contrast enhanced CT scan is done to outline the pelvic ileal system and the ureter. So this is an X-ray abdomen, which shows non-specific bowel gas pattern, and we will focus on the clinical indication of lost IUCD. So whenever on clinical examination, IUCD cannot be located or the thread is not seen, then the first line modality should be ultrasound. And if the IUCD is not seen on ultrasound, then an X-ray abdomen can be done to locate the IUCD. In this case, you can see that this IUCD, although there within the pelvis, but this is abnormally located. Ideally, it should be like a T with the long here, long arm here, and then the T over here. But in this case, you can see it appears to be horizontally located, and hence it is abnormal location of the IUCD. These are multiple images taken from transvaginal examination. As you all can see that the endometrial thickness is around 12 millimeter. And in this case, you see an abnormal hyperechoic structure, which you see here, which is extending from the endometrial cavity within the myometrium. So this is another case of abnormal location of the IUCD. So whenever the patient comes to you for localization of the IUCD on ultrasound, you have to see that it lies within the endometrial cavity and preferably in the region of the fundus. So if it is located low lying in the region of the body or in the cervix, then you have to mention it in your report and say that the location of the IUCD is not ideal. History not provided. Yes, as you can see. So this patient had abdominal pain, and the X-ray of the abdomen was done, which again showed non-specific bowel gas pattern, some fecal loading within the large bowel. But what you see is a ring-like structure within the pelvis here. You all see this ring-like structure. So this ring-like structure is a vaginal pessary. So there are a number of indications for placement of this ring-like structures, that is the vaginal pessary, and it comes in different shapes as well. A few indications are for uterovaginal prolapse, for cystocele, for incontinence, etc. So whenever you see these vaginal pessaries, you have to be sure that it is normally located, and you write it down in your report. So these are images taken from per-abdominal examination, and in this case you see that the uterus is anteverted, and we see an iso to hypoechoic, well circumscribed lesion anterior to the uterus. It is inseparable from the uterus, and the finding is due to the subserosal fibroid. So fibroids can have varied echogenicity on ultrasound. They may be hypoechoic, they may be isoechoic, and they may also be hyperechoic. Hyperechoic due to degeneration, due to calcification, etc. When there is a cystic degeneration, they may also show cystic changes within the fibroids. An important thing to note is always remember to put Doppler on the fibroid just to be sure, and to see if there is significantly increased vascularity or not. And then you need to be sure that you are not missing out on any sarcomatous change within the fibroid. So these are MRI images, sagittal, axial, um, of the pelvis, and in this you see an abnormal signal intensity large lesion which is arising from the anterior wall of the uterus. So this is the anterior myometrium and it is continuous with the anterior myometrium. It is hypointense on T2. Another slightly isointense lesion is seen in the posterior myometrium as well, this one. So these are the fibroids, and they may have, again, like on ultrasound, fibroids may have different signal intensity on MRI as well, but predominantly they are hypointense, but they may also be hyperintense on T2, again due to multiple reasons of predominantly they enhance slightly less than the adjacent myometrium, but mind you, fibroids may also sometimes enhance more than the myometrium as well. So whenever for routine evaluation of the fibroids, MRI is not done, but MRI is done when the surgeon is planning to remove them, do the myomectomy for the fibroids, and in this case you have to tell the exact location of the fibroid. So in this case, this is a subserosal fibroid, and the one posterior one is an intramural fibroid. So these MRI images shows enlarged uterus. As you all can see, it appears globular and enlarged, and there is diffuse thickening of the junctional zone. If the junctional zone is more than 12 millimeter, then you say that this is adenomyosis. Less than 8 millimeter, you can safely rule out adenomyosis. So there is enlarged uterus with diffuse adenomyosis in keeping with the history of menorrhagia. But there is an abnormal signal intensity lesion within the posterior myometrium, which you all can see, and it appears to be slightly continuous with the endometrial cavity here. Okay, so this is a case of diffuse adenomyosis, and for this abnormal signal intensity lesion, we thought it may be a fibroid, but it came out as an infarcted polyp. So this was an endometrial polyp which has undergone infarction, and as a result, it is not showing enhancement on post-contrast images as well. Of an endometrial polyp which has prolapsed into the cervical cavity. Sometimes what happens is that the clinicians say that there is an being when we push hard on the vagina, we reach up to the exocervix, and then we tend to obscure it. So whenever there is a high clinical suspicion for an cervical polyp which has prolapsed, just pull out the probe a little, and then you would be able to see these lesions. Images taken from per-abdominal examination as well as transvaginal examination. In this case, we see a slightly hyperechoic area within the endometrial cavity. You all see it, and it is showing vascularity on Doppler. You see the vascularity. Uh, if you compare it with the previous one, this vascularity is not stalk-like as we see in cases of endometrial polyp, but it is more of slightly haphazard within this endometrial cavity area here. So in keeping with the history of amenorrhea with bleeding PV, this is appearance is due to retained products of conception. So if the history is not provided, like if only an image is given, then you can give the differential of an endometrial polyp or an RPOC. But with the history, which suggests amenorrhea, your first differential should be RPOCs. Heavy bleeding PV, beta ICG is negative. So this patient was a CA breast patient and she came in ER with heavy bleeding PV. And when we did a transvaginal ultrasound, we saw this echoes within the endometrial cavity, which is seen with hemorrhage. And we saw a sac-like structure here. But on some images, it appears with this as hemorrhage. And we saw a tiny hyperechoic area here. And we thought that this is a pregnancy patient, but beta HCG came out negative, and then the differential was an endometrial polyp. So endometrial polyp can present in different ways. You see that this is a tiny polyp, but it has led to so much of bleeding. And then an MR of the same patient was also done, which reproduces the findings. We see this iso-intense lesion, which is protruding within the endometrial cavity. We see some blood and fluid level here, and you see that polyp is enhancing. The case which I showed you earlier was an infarcted polyp. Most of the time, polyp will introduce, almost all of the time, the polyp will protrude within the endometrial cavity, like you see in this case here, and it will enhance as we see here. So multiple sections taken from MRI examination. We see an abnormal signal intensity lesion, which is hypointense, shows some cystic areas within the endometrial cavity. It is causing dilatation of the endometrial cavity here. And on T1, you see some hyperintense foci within it, likely due to hemorrhage or proteinaceous material. And as you can see, it is enhancing significantly on post-contrast examination. This is a typical appearance for an endometrial polyp. So sometimes it is difficult if you want to see whether there is some malignant transformation or not. And in those cases, diffusion weighted images are really very helpful. And if there is some malignant transformation within the polyp, then there will be diffusion restriction. So we see the endometrial cavity is enlarged, globular, abnormal shaped, and on subsequent examination, we see there is free spillage of contrast from both sides. The tubes looks patent. So this appearance of the endometrial cavity is due to presence of a fibroid. Fibroid may cause enlargement of the endometrial cavity. It may distort the shape of the endometrial cavity as well, but it will be somewhat smooth as compared to any lesion or adhesions or synecdoche. This enlargement and distortion of the shape will be smooth if it is due to fibroids. Another case in which you see significantly enlarged endometrial cavity, but the shape somehow is maintained and the tube looks patent. And on ultrasound, we see that this is a large intramural fibroid. And in this case, you can see that this fibroid is more hyperechoic when compared to the adjacent myometrium. So as I said earlier, also that fibroids may have different echogenicity. So Hysterosalpingogram examination, the uterus shows an outpouching in the region of the cervix. This patient had a history of C-section, and this type of appearance or outpouching in the region of cervix is due to the scar of the C-section. So if you find this type of outpouching in the region of the cervix, always think of cesarean section contrast extending into the cesarean section scar, and the tubes are patent as you all can see. Hysterosalpingogram examination. But if you find an enlarged uterus, like you see in this here, and irregular outline of the endometrial cavity and multiple outpouchings, as you see it here, then this is typical for adenomyosis. You see these are small outpouchings everywhere along the endometrial cavity. The diagnosis is adenomyosis. This lady came to us for HSG examination. She was like 39, 40 years old. And there was no other history. What we found was the uterine cavity was slightly enlarged. I wouldn't say it's small, and it's very irregular in outline with some filling defect within the body as well. This case was very challenging to us. We took her for ultrasound and we found significantly thickened endometrium. And looking at that with increased vascularity, we raised the suspicion for endometrial neoplastic lesion, and on subsequent histopathology, it proved to be such. So this needs to be differentiated from small endometrial cavity due to which can be seen due to synecdoche and multiple DNCs, etc. But here you see that this endometrial cavity is pretty large. So this type of appearance, if you see, always take the patient for an ultrasound also and see if the endometrium is fine. Infertility, Hysterosalpingogram examination is done. So here we see two endometrial cavity, but the cervix is one, as you see it here. And then the two horns are separated. The angle separating them is less than 90 degree. As you all know that if the dip is more than 1 centimeter and the angle is less than 90 degree, then this is due to septate uterus. The tubes are patent, as you can see by the spillage of the contrast. Another patient, yes, this is again a septate uterus with multiple air bubbles within the uterine cavity, but here you see that there is bilateral hydrosalpinx and the tubes are also blocked. So normal tubes, they are hair-like as you see here, but here you see significantly dilated and tortuous fallopian tube. Similarly, on the left side, you see mildly dilated and tortuous fallopian tube. So this was a case of bilateral hydrosalpinx with blocked tubes and a septate uterus. Banana-shaped uterine cavity and a single tube. Spot diagnosis is a unicornuate uterus. But let me show you similar case of another patient. Again, this is a banana-shaped uterine cavity. We see the tube is patent. We see spill of contrast. But when we did the ultrasound of the patient, we found that this is the left horn and a small rudimentary horn on the left side. This one. This is the normal uterine cavity, and this is the rudimentary horn of a bicornuate uterus. So, if you are given this type of image, you will label it as unicornuate uterus. But if you are given both, look at the ultrasound again to see if there is any rudimentary horn which is there on the ultrasound image, just to be sure that you are not missing on any finding. So this is another HSG examination. We find that this is significantly distorted cervix, and uterine cavity maybe looks okay here, but we find some abnormal appearing calcified bodies within the pelvis here. So this was again a challenging case for us as well. The tubes are again patent, and we took the patient. In this case, you will ask me if you have to write down in the exam. So you will write about the abnormal appearance of the cervical cavity, and you say some calcific bodies are seen within the pelvis. And when we say calcified body, calcified structures within the pelvis, the fundus of the uterus looks fine. You see, this is the fundus and the part of the body of the uterus. You think of calcified fibroids. So when we did the ultrasound of this patient, we found calcified multiple fibroids in this patient. And then we did a plain film of the patient and we found large calcified areas within the pelvis due to the fibroid calcification. So multiple Images taken from per abdominal examination, you see an intrauterine pregnancy, yolk sac is also visible here, and we see a calcified structure in the anterior myometrium here. Okay? So again, the calcified fibroid will have calcification at the rim. So this was a calcified fibroid in the anterior myometrium here, looking like a fetal head. History of 8 weeks amenorrhea. So easy to pick. There is an intrauterine gestational sac, fetal pole is also seen, but we see a linear echogenic structure within the cervix. So this is an abnormally located IUCD with a viable pregnancy in normal location. Images taken from anomaly scan. So this, whenever you do an anomaly scan, you have to look at the shape of the fetal head, and in this case, we find that there is some bowing there is some compression in the frontal region of the fetal head, and this is called the lemon-shaped fetal head. And then we looked at the posterior fossa, and we find that this is small and banana-shaped cerebellum can be seen, right? The ventricles are dilated, as you all can see. And then you have to trace the spine and along its entire extent. We see this is the cervical region, this is the dorsal region, and in the lumbosacral region, we find widening of the cervical canal, and this was a case of meningomyelocele. And summing up all of the findings, this is Arnold-Chiari malformation. 12 weeks amenorrhea with abdominal pain. So images taken from parabdominal as well as transvaginal examination. What we see here is, I will take you from the beginning, that is, this is the uterus, some fluid within the endometrial cavity, and as we come down, like I have mentioned it here, cervix, we see a gestational thick-walled sac-like structure here with the fetal pole inside here. This is it. And here we see some vascularity, we see the fetal pole, and this patient had a history of prior C-sections. So whenever in a patient with C-section, you see the gestational sac extending into the scar site. So this is a case of scar pregnancy here. If there was no history of C-section and you find a gestational sac in the region of cervix extending into the wall, then you say that this is a cervical ectopic pregnancy. But in this patient, there was a history of previous C-section, so we called it as cervical scar site pregnancy. You have to differentiate it from an inevitable abortion, right? So how do you differentiate? You will not find an aborting sac extending within the wall of the uterus, one point. Second point is, you will not find vascularity in the wall of the sac if it is aborting, right? And the third thing is, when the scar pregnancy can be endophytic or exophytic. So it may pass into the scar, implant there, and may extend outside also when it's called exophytic, or when it extends more within the endometrial cavity, it is called endophytic. So this patient had history of amenorrhea and presented with abdominal pain. This is easy, so I will just quickly go through it. You don't see any pregnancy within the endometrial cavity, and then you have a history of amenorrhea. You locate the normal right ovary here, and you locate a sac-like structure in the right adnexa. This, we have measured the fetal pole here, and there is fluid in the hepatorenal pouch as well as in the pelvis. So this was a ruptured ectopic pregnancy. So whenever you write down or describe ectopic pregnancy, it's important that you mention about free fluid and you look for it, because if it is ruptured, there will be free fluid, and then You have to mention it in your report and inform the primary as well. In either case, you have to inform whenever there is an ectopic pregnancy, but again, this is too much emergency because the patient will collapse due to the intense hemorrhage within the body. You have cases of twin pregnancy. You have to differentiate whether this is diamniotic, dichorionic, and you have to mention it in the early pregnancy. So I will just tell you this is the lambda sign of diamniotic and dichorionic pregnancy. So the two placenta have fused and they are extending into this amnion, resulting in the lambda sign. So this is di-di pregnancy, that is diamniotic and dichorionic. The other sign is the T sign, which is seen in diamniotic and monochorionic pregnancy. So, and another image, a few other images that are taken from the anomaly scan. So when we look for the fetal head, we don't see it. We don't see the cranial vault. I show you. So we don't see the cranial vault. We only see the eyeballs, the frog like eyeballs, and we don't see the brain or the cranial vault. So this is a case of anencephaly. Question mark, morbidly adherent placenta. This is very common now because of increased C-sections that are done these days. And this is a condition where the placenta adheres to the myometrium. There are 3 grades of morbidly adherent placenta: accreta, increta, and percreta, right? So whenever there is history of previous C-section, and you see placenta previa, like in this case, you see complete placenta previa, then you put on Doppler. Always make it a point to put on Doppler whenever you see placenta previa, and especially if there is a history of C-section. In this case, when you put on the Doppler examination, you find the vessels extending through and through the myometrium, the bladder wall, into the urinary bladder. So this was placenta percreta. And the good thing is that this is the least common. The commonest is accreta, which is not so severe as compared to percreta. So an important point, take-home point is whenever you see placenta percreta or any grade of morbidly adherent placenta, it's important that you inform your primary physician. So this patient had a history of DNC. Per abdominal ultrasound examination, we see an abnormal heterogeneous area in the anterior myometrium. When we put on Doppler, not significant flow on seen. And the differential for this appearance are, we had no previous examination of the patient, and considering the history, the first differential is hematoma formation secondary to the procedure, and the second differential would be a degeneration within the fibroid. This patient also underwent MRI examination, and as you can see, this did not enhance and finally labeled as a hematoma. Postpartum status. So in postpartum status, if there is significant hemorrhage during the pregnancy, the patient may develop acute cortical necrosis, and in this case you can see that there is no enhancement of the renal cortex, there is enhancement of the medulla, and the uterus is enlarged, and it shows a heterogeneous area within it which is not showing enhancement on which is not showing any contrast enhancement. So this was this is due to the blood clot and enlarged uterus. We also see some fluid surrounding this blood clot as well. So postpartum status, enlarged uterus with the blood clot, fluid, and resulting in acute cortical necrosis.